Thank you very much, Mick. Can I get the speakers up here for the discussion? So, any questions from the audience? There's a question there from Bill Myers.
I had a few comments. First of all, I think it was a fascinating group of talks, and it's right along the line that where my bias is. We got to be speaking anatomy and figuring this stuff out, and it's great to have a fellow Dookie here speak as well, and that the experiment that was done was fascinating. I mean, I'm glad you didn't pick me as a subject. But you have to watch out, perhaps with the word referral, that sort of suggests a neurologic pathway. It could be reflex types of problems and or reflex types of responses. But a few comments about the anatomy. I just presented a paper at the ISHA meeting, the International Hip Arthroscopy meeting in Rio a couple of weeks ago, and it was on 27 fresh cadavers that we'd done over a number of years. And with our clinical experience, I keep on going back to the lab with my folks, to the fresh cadaver lab, to look at different aspects of things. And there are some pitfalls in the fresh cadaver lab, just because you get primary.
Is there a question in there, Bill, so we can get to the question, please?
Get primary older people. But it's primarily a couple of comments. One is there really is a thick cover, fiber cartilage of the pubic bone, and that the anatomy picture you showed really shows what the majority of our cadavers did show. There's not a tremendous amount of tendon in there. I mean, but it is very variable, and so I think we need to keep that into account, and you can actually find some fluid deposit between that cover, which you can peel off often in the fresh cadaver, and that gets into all kinds of speculation about what causes osteitis. The other comment is don't underestimate the pectineus in terms of all this. The pectineus is an important muscle. The adductor longus certainly is important too, and the adductor brevis is important too.
Can we? Yeah, excellent. Thanks. Because that would be my question. Because you were talking also about the unspecific groin injuries, and you were mentioning that, Dr. Hellmich. And so what are we missing with this clinical entities approach? What are the kind of injuries, if we also consider the talk from this morning with Andreas? What do you think we are missing with the current approach, or are we missing something?
I'll take this one. Fine. Yeah, I think we are. If we go back and look at some of the long lists of diagnoses that we saw in the talks that people were giving in the old days, where you could fill 5 slides with a lot of different things that were giving rise to pain in the groin. They're probably all correct, and some of them we would miss. It could be nerve entrapments that were very high fashion 30 years ago and were a number of papers there. And there's no doubt sometimes, in my practice it's rare, but I see patients who have nerve entrapment problems. It could be pain radiating from abdominal structures. It could be pain from lots of other things, but they are the rare ones. And I think in my experience and from also I think what we heard today is that, and seen from the epidemiology this morning, is that we can focus on the muscles, tendons, and what's related to that, including the inguinal canal, and then to the hip joint as well as the major causes of groin pain.
Okay, but just to comment, because there was a few suggestions that might like the pectineus comes up in acute studies as well, and these structures are not that easy to identify by palpation. for instance. So is there any of those where you think here we might need to add something other than the clinical examination?
Yeah, I agree. The pectineus that also Dr. Myers mentioned is a problem because it's a muscle that is a little difficult for me, at least, to test individually. You can palpate it, you know where it is. We've looked at it for a long time now, especially since I saw the numbers in Andreas' paper where there's actually identified injuries to the pectineus in the acute setting. And I never really managed to diagnose that many in the long-standing setting. So either it was a benign muscle, or it would be a situation where it's something else. It's very close to the iliopsoas, and you have a iliopsoas lesion. There might be some spreading of the edema or even the bleeding to that muscle. So to me, the pectineus muscle is something that I'm trying to look into right now. I haven't found any papers, anything in the literature that are describing how we go about finding the specific diagnosis, at least not without imaging.
There's a question from the back as well. Just, yeah, thanks.
I'm Ahmed Al-Khair. I'm a rehab PMR doctor from Al-Ahli Hospital. This is a question to Michael Drew. You injected, if I understood correctly, you injected healthy with normal saline and hypertonic saline to induce pain. And you are trying to draw some mapping of pain representation. Did you look at the other aspect? Did you see how people actually with the rectus, with a muscle injury, how do they draw their pain and compare them?
Thank you for the question. We didn't specifically look at the test in relation to the rectus femoris. That was our control question. It's been asked of me a couple of times as I've shown some of this data, but I think we need to take into account that the adduction tests aren't really, no one would clinically use them for the rectus femoris, so I don't see the point in finding the likelihood ratios of a squeeze to predict the rectus femoris. For me, from a clinical point of view, it seems a bit abstract.
Did you see the unhealthy volunteers? Did you see people with injuries of the muscles that you tested on volunteers, on a normal, on healthy population? So you tested a couple of muscles on healthy population, correct?
Yes.
Did you look at people with injury of these muscles? How do they map their pain?
No. So that's our next step. So to establish, something to compare against, that's why we use the healthy male population, and then our next step is to look at the long-term groin injuries. What I didn't present today was also some pain pressure threshold data. We also did McGill pain questionnaires, so how do they report their pain? EMGs of the diagnostic tests, so in the presence of pain, how does that actually change their output? And our next step is to actually look at the pain pressure thresholds over a large population in Australia. We're also looking into the full quantitative sensory testing bundles of temporal summation of pain and hot and cold and all these other things to see if there's some sort of pain science approach to these populations as well. But to answer your question is, no, we haven't moved into the clinical population yet. We did have one guy that volunteered for the study, and then once we'd spent the hour putting all the EMGs on and tweaking all the little gadgets, and then he said, I was out for a couple of months last year with groin pain. So we did test him in the test, but we didn't induce any pain in him. He was then excluded. So I do have a case of someone with prior history too, but we didn't go further than that, and I haven't analysed it yet.
And just to add on that is, how did you, when you sensitized these muscles, how was that the clinical picture of these? Were they mimicking the adductor-related patients, or was it the full muscle being sensitized, or how well does that model reflect a clinical patient, do you think?
It's quite abstract. I got injected myself. Before we were allowed to do it to the participants, you have to go through it yourself, and so it is a bit of a string to draw between them. But I think what we're trying to do is say, well, this is what pain does, and the next step is then, does this model replicate them? So do they describe it in the same respects? I think there is some definite separation of the two pain models.
Thanks. There's a question from Rob Langhout.
Thank you. Rob Langhout from Holland. Dr. Schagge, thank you for your clear biomechanical presentation. I'm very interested that you calculated the adductor moment much bigger than the psoas moment, if I'm correct.
Yes.
70 against 5.
The adductor moment for adductor longus or the flexor moment,
Yeah.
Sorry, the adductor moment for adductor longus or the flexor moment?
Adductor longus flexion moment.
Yes.
Yeah.
It's around 4 to 5 centimetres. But if you look at someone if you think about the sagittal plane of the body, the adductor longus is sitting on the very front part of the symphysis, whereas the iliopsoas is more or less wrapping right around the front of the hip joint. So that result is somewhat intuitive, but I just don't think it gets appreciated as much as what the numbers would actually tell us.
But it has consequences for testing positions.
Correct.
But can you the maximal muscle moment, is it in extension of the adductor longus or in flexion? Do you know the position in which it has its biggest moment?
I would hazard a guess and say when the hip is in extension, it's going to elicit its greatest power to produce a flexor moment. Once you get up to a 90 degrees of flexion, the adductor longus has already become either, it doesn't really have a moment arm for flexion or extension, or it's become a slight extensor. Hence the specificity of 90 degrees of flexion to the iliopsoas, which still has a flexor moment arm at that angle.
And last, if I may, and the psoas has its biggest moment later in the movement.
Yes. So it sort of
first
has
adductor and then psoas.
Yeah. So the moment arm for iliopsoas is less than the adductor longus, but adductor longus deteriorates as you flex the hip. Psoas sort of peaks around that 30, 40 degrees of flexion and then starts to drop off a little, but it still always maintains an appreciable moment arm to produce flexion.
Thank you.
And we'll round up with the last question, and that's for you, Dr. Raymond. So how can we move forward now with this? How do we come up with a better way of examining the hip and actually making a difference from pre to post?
I think the difficult thing is that we need to try to apply these tests over a larger, wider spectrum of patients, meaning, across European League soccer and those kinds of things. The problem is there's so few numbers that truly have hip intra-articular pathologies. It's probably going to be a large study. But the biggest thing is we need to figure out, these tests might be great tests, but currently the way they're performed is they only show the ability to rule out versus rule in. And so I mean, that's still valuable. I mean, it's still valuable to you as a PT. It's still valuable to the surgeon. The problem is that they're so frequently positive, especially in a surgeon's office, is it's almost like, so what? And so we need to truly figure out, do these tests truly differentially diagnose those people that have pathology versus those that don't? And in order to do that, we have to do these on people that do not have the pathology and make sure that they're truly negative. The difficulty with that is you're not going to be able to use a surgical I mean, you don't take these people to surgery for that. So,
thank you very much. And thank you very much. We're going to close this session. Excellent talks, everyone. Thank you.